Hi everybody, thanks for joining us. This is the latest episode of the 50 Shades Show. I'm here with Charles Beaton, who's a patient I've known for years. He's been kind enough to be willing to share his experience about what he's been through and what we've done for him. Kind of the purpose of doing this is kind of a continuation of what I was talking about the last time I went live, which was that it's hard for any of us to be vulnerable. And I'm of the belief that we have a hard time being vulnerable because we're afraid of judgment, we're afraid of what people will think about us. But that I have learned that in doing so, in being vulnerable in a safe community, that it's actually a growing experience and it helps me grow. And so part of what I want to try to develop in our practice is a community of trust and support where we can feel comfortable, I mean myself, my team, the patients who are here, we can feel comfortable being ourselves, being comfortable with vulnerability, and then helping each other, giving us each other support and growth. Like I was talking about an injury that I've had in my knee that I've been working on, and it's kind of hindered me from exercising and from jogging, taking care of myself. But in doing so and telling people about what I'm going through, what I'm struggling with, and what I want to try to grow, I actually get a lot of support. And so I've asked Mr. Beaton to join me today to talk to us about his experience and what he's been through, the struggles that he's had, and what we've done to help him grow and improve. So introduce yourself.
Well, I'm Charles Beaton. I am 60 years old. I'm a retired EMS worker, got hurt at work in 2007, had all this, had my arm tore up, nerves tore up, and went to UK, or they rushed me to UK for surgery, and it didn't go good. So then they sent me to another doctor at Central Baptist. Can I say his name?
Well, you can if you like, but you can just kind of tell us the story.
There was another, what they did, they kind of operated and they wouldn't let me move my arm. I couldn't move my arm after they operated the first time, and it started turning black. So they rushed me over to Central, another hospital about 6 weeks later, and the doctor that sat on the hand transplant up at Louisville, he was my doctor, and in 3 days I was on his operating table, and he got the color back, cut everything back. I can't lift more than 9 pounds, but he got it back. But I was on so many pain pills. I was on like 6 hydrocodone a day and Oxycontin at night, and I did that for like 6 years. And then the doctor that, my pain doctor, he left town, and they gave me a choice, and a couple of people told me about Dr. Danesh here, and I come in, he sat down, he talked to me, he asked me what I wanted. I told him I wanted off the pain medicine because I lost half of my life. I don't remember a lot of what happened in my life those years because I stayed doped up all the time, and it took 4 years, 3 or 4 years. Mm-hmm. It took several years to get off of everything, and I get my shots, and I went out and got a part-time job. I walk now. I got a big dog. I do it all now, and I didn't for years.
Now, a lot of people come to us and they've been on pain medication and they're afraid of coming off of it. They may want to. I mean, just like you, I've had many patients who come in and they say, I've been on pain medication, I have these blocks of fog in my life, but I also see patients where they don't. They feel fairly fine with their pain medication.
I was scared to death I was going to become addicted bad, and I was scared that you was going to try to take me off of them, and I was going to sneak around and try to buy them. I haven't had that problem at all.
And I think it's important to make a distinction among 3 different entities, which is physical dependency, which you had.
Yes.
Because if you didn't take it, your pain would just go through the roof.
And also every 3 hours, I started shaking.
Right.
I had to have that next pill to stop shaking for the next 3 hours. So,
right.
Yeah.
So there's definitely some physical dependency.
Yeah.
There was some tolerance, meaning that you needed higher doses, higher and higher doses, just to get the same effects you were previously.
Yes.
But then there's the fear of addiction too. And while all of this is on a continuum, addiction is not that common, but physical dependency is almost universal. The reason I make that distinction is because this is an area of medicine that's full of stigma and full of judgment. And a lot of that stigma and judgment is actually internal.
But also, I used to live in Georgetown. I'd go to this certain drugstore, and they were whispering one day, and a friend of mine worked at the drugstore, and the people would say, "Here comes a dope head right now." Because I'd always go there and get 250 hydrocodone a month, 60 Oxycontin a month. And they would say, "Here comes a drug addict." And she told me that that's what they said. So I took my business to another drugstore where
it's a bad feeling.
it's an awful feeling.
It's a terrible feeling.
It's an awful feeling.
Yeah.
And the friends would say, "Hey, let's go here." And it got to a point where they stopped asking because I didn't want to do it because I was like in that fog. I was kind of scared to go out and do anything.
Yeah. And I see patients in that state a lot. One of the problems I see in healthcare is that for years and years and years, the mantra was, if it hurts, then give it pain medicine. If it's not enough, give it more medicine. And very quickly, we see people who really, they were not a good candidate to begin with for pain medicine, that they had issues that wouldn't respond to pain medicine, or that they had issues that would only get worse with pain medicine. And so instead of addressing the main problem, people just get started on this pathway of pain medication, and it evolves into this place where nobody's in control anymore.
I was scared. My dad's side of the family was alcoholics, and that scared me because I was scared I was going to be weak and I'd have to have that.
Yeah, and I think that's a legitimate fear, is that you know, if you have a history of addiction, you are going to be at higher risk for addiction.
Mm-hmm.
But the thing to create a distinction is that addiction is not a behavioral fallacy. It's not like it's a weakness of moral aptitude. It's that that the medicine actually changes the way your brain processes these signals.
Trust me, it does.
And addiction is not people's fault.
No.
As much as it is just chemical changes or physiologic changes in the brain.
Yes.
And that I wouldn't qualify what you were dealing with as addiction. I would say that there's a physical dependency, but addiction involves behavior. I think addiction is more a disease of coping, of mechanisms to cope, of knowing how to cope and how your brain works around struggles and stresses, as opposed to it becomes a scapegoat for your pain. And that's an important distinction to make, because if we're ever going to get ahead of the opioid epidemic, it's about starting to triage people and getting them the appropriate resources. Like in your situation, what we needed to do was actually start fixing the problem, or start treating the problem, as opposed to just trying to mask it with the pain medication.
I was scared to death to come off of them. I was really...
And so talk to us about that experience. Like, as we started treatments, what happened to your pain versus what happened to your dependency on the medications?
Well, like I said, we started cutting everything down. It was everything down, then the methadone, cutting everything down. And like I told you before, a little pain's nice. I know I'm here. If I didn't have a little pain, I would not know I was here. Because when I was on the drugs, I did not, honest, I would stare at a wall for hours, you know.
Was it as hard as you thought it would be?
Not the way you did it. I mean, not the way you did it. It wasn't as hard as the way you did it.
So how did we do that? Was a combination of things.
Of shots, of cutting the pills down, a little physical therapy, and
yeah. I think that's about right. So because the strategies that I'm using, I'm trying to, we want to separate out your experience of pain from the damage that exists. And the damage was not being addressed. It was just the pain was being addressed, but the damage wasn't being addressed.
That's why physical therapy, they was doing what they call dry needling.
Right.
For a while.
Which dry needling people think of as you're just kind of poking somebody with needles.
They hook them up to electrodes and.
Right. It's more of a neurological stimulus of trying to recalibrate what your nerves determine as being problematic signs versus normal.
Yep.
And there's a bunch of inflammatory changes that takes place with that, but the sum of it is to try to recalibrate what your nerves see as normal and not normal.
Yeah.
There's that involved. After your surgery, your nerves were really enmeshed in a lot of scarring.
Yeah. That's what Central Baptist doctor said. He said, I scar bad.
Yeah.
I mean, I've had open heart surgery. I scar bad. So, and this right here is really the worst, I think.
And the classical thinking is that scars form and they never go away, and that's not true.
No.
Because one of the things that they were doing with you in physical therapy was they were actually maneuvering that nerve to try to get it to glide. We think of nerves as being these stable elements, but if you think about it, if my hand is like this and there's a nerve running from my pinky all the way up into my neck, well, what's going to happen if I extend this hand out? That nerve's got to stretch out there.
Yeah.
And so nerves are actually dynamically moving within the tissue, but if it's scarred in somewhere, it's not going to do that. So every time you moved your hand, it'd be like a shearing tug force on that nerve, and that's going to create an irritation and set everything off again.
Yeah.
So one of the main goals we had was to try to help liberalize that nerve to get it moving again. And that took a combination of physical therapy.
Yep.
We were doing injections around the nerve where we're just dilating the space, and I'm looking for areas where the nerve is actually scarred into.
Well, you asked me where it hurts at the most, yeah.
Right, and so what I'm doing in those situations is that I'm actually looking for where that nerve might be entangled. And in a moment, with Mr. Beaton's consent, we're going to do an actual neuroprolo injection, which is different than what we've been doing. And that injection is going to use some medications that actually breaks up some of the scar even further, and then stimulates a repair process where your cells can come in and actually develop a sheath around that nerve as opposed to just living with that scar. So I'm anticipating this injection is going to give you even more benefit than what we've had in the past.
Because after it wears off, I can tell when it's wearing, the first shot's wearing off.
Right, and our goal is to get you to a point where it progressively improves. Now, the impression I had is that you have seen progression with this.
Oh yes, a lot.
Yeah, tell us a little bit about that. Like, what was it like before we ever started these treatments?
I was just wearing my right hand out, my right arm out. Everything was with my right arm. I was bringing everything to my right arm, my left arm. But now it was like this, but now I can do this right here now.
Yeah.
I still can't lift a whole lot with it.
Still weak.
Still weak.
Yep.
Walking my dog is kind of rough with it.
Yep.
I wanted to train her to the right side, but he trained her to the left side, so.
But Bailey's a good dog.
Bailey's a good dog, 110 pounds.
So the treatments that we do, we'll go over to the ultrasound room and take a look at Mr. Beaton's nerve under ultrasound. And I think last time we took a look at the left side and the right side.
Yeah, and you saw something that.
Yeah, so there was definite scarring around that left side. That,
you can see it.
You can see it, and that progressively over time we've seen a reduction in that scarring with movement of that nerve, and we can show that. And if anybody has any questions for myself or Mr. Beaton and what he's been through and what he's dealt with, by all means chime in. I just want to kind of express my gratitude for you having the courage to talk about this, because the more we can talk about this as a community, the more courage people will have to face the demons that they have. I mean, I know how scary it was for you at the beginning to just come face to face with, I want to change something, and giving us your trust to figure out how to do that. We appreciate that. So we're going to transition to the ultrasound room, and then that'll give you an opportunity to see. It looks like I've got a message from Tina Henson. You are definitely making a huge difference in people's lives. Thank you, Tina. This is a friend of mine from Denmark, and I'll be seeing you in December. Looks like, yeah, that's the only person we have. So, all right, so you're gonna get a bumpy ride into the ultrasound room. It's just really noisy in there. So we're gonna, that's why we were in the other room, but we're gonna come into here, and I'm gonna set this up over here so you can see the monitor and see us. And then Mr. Beaton, if you wanna go ahead and lay down on your back. I'm gonna drape this over you. Hopefully you guys can hear me. So I just want to take a look at the two sides and just show the difference between the two nerves. Let's get this monitor in closer. All right, I'm gonna reach over you so that I don't have to keep changing sides. But that object right there, I know it's fuzzy, but that's the nerve, and if we can kind of trace it down. It's right here. I don't know if my head is blocking the view or not. Let me adjust this a little bit so you can see. You're gonna have to trust that Mr. Beaton's down there and he's doing okay. He's alive and well. All right, so here's the nerve again, and as I trace it down, it goes into this little groove. You're going to see it coming up here, that little groove right there, and so that's the cubital tunnel right there. That's where the nerve crosses through the elbow and up through the other side, so kind of this area right here. And let's do that on the right side. So here's the nerve on the right side, and let's switch over to the left side now. You can relax this arm. So just take a look at the difference between these two. You see how that's nicely enmeshed in the tissue, and it's kind of healthy in its separation, its diameter, whereas on the other side you can see how the nerve just looks like it's a thicker nerve. You can't really get a good delineation between the nerve itself and the tissue around it. It kind of all meshes together, and then especially as we get into this groove, I'm going to have you straighten this out a little bit. Especially as we get into this groove, you can see how the nerve just loses its definition as it's making this curve. It just kind of blends in with everything else. You don't see this nice definitive border. Last time we were looking at the nerve kind of in long ways. Just watch what this does. So, let me get that view again. Alright, move your wrist up and down. And you're going to have to take my word for it. You might not be seeing his wrist moving, but it is moving. In fact, why don't we do this? Why don't you hold this up and move that wrist. See, there's no movement in that nerve left and right. Now, let's look on the other side.
We were moving the whole arm too.
Yeah, we were moving the whole arm, but I'm gonna, where'd my stuff go? I think you're gonna still see it move with the wrist. Oops. Alright, now let's do this side. Alright, here's that nerve. See how much movement that has? It's the same nerve on the right side as it was on the left side. I'm going to freeze that again. We're going to come back over here and switch to left. Oh, I messed that up again. Alright. Same nerve in cross section. Now go ahead and move that wrist. It doesn't even move. And that is, let me see if I can play those two back. So, see how much movement there is here? There's no movement in that nerve over there. And that's essentially the entrapment that I'm talking about. That's what we've been trying to release this whole time, is to liberalize that, get that nerve moving a little bit more, and we do that by doing these injections around that nerve. And so what we're going to do, if you're okay with it, I'm going to go ahead and do another injection here and see if we can release that a little bit. And then I don't think that we'll get a lot of movement, but it's through the process of just repeatedly injecting this that we will get more and more movement. I'm going to move this down a little bit. So now I want you to just keep an eye on that screen. I'm going to put some gloves on here. Yeah, yeah. And I've got some of my neuroprolo mix already drawn up. And this is the medicine that helps to stimulate repair cells to come into the area. And what we're going to do, you'll see me enter with the needle, and I'm going to start making a space around that nerve. All right. Here comes an injection. Ready? 1, 2, 3. And you can see my needle coming in. I'm just creating some space around that nerve, trying to pick out areas where it seems like there's scarring that's holding the nerve in place. I'm just picking off the scar tissue off of that nerve.
Let them know I hate needles with a passion.
As in, were you EMT?
Yeah.
As an EMT, I think it's natural for you to hate needles. I think most healthcare workers hate needles.
I wouldn't be doing this if it didn't work, you know.
Yeah, Mr. Beaton's saying that he wouldn't do this if it didn't work. That's how much he hates these needles, but it does help. You see, like right there, there's a little bit of scarring that's not letting go of that nerve. This area seems actually pretty good. I'm going to move down a little bit further. And so you see less definition here. This area is really scarred in. Yeah. So I think I'm going to reposition my needle so I can get a better angle at that. Yeah, this is the area where it looks like it's really, little pinch. Looks like it's really scarred in here. You can't really get much definition out of any of that tissue.
That's it. That's it.
That's the spot, huh?
Mm-hmm.
Yeah, we're just going to slowly peel away some of that. Now we can start to see the nerve, define it from the rest of the scarred it in around it, and with care I'm separating out the nerve from that tissue. How you holding up? How's it feeling? So, as it gets into that canal or that groove, that's where it seems to be a lot more tight. And again, loss of a lot of definition in that area. See how the nerve changes from here, where it's more well defined from its borders. It starts to lose that in this area here. And that's where all that problem is. So I'm going to come back in here a little bit more. And help to redefine that. That space seems to be opening up nicely. We're good for now. Like I said, it's not a overnight process. It's a process just progressively opening that up. There's stuff on the horizon where we can use something that is more of a natural lubricant within the body and try to actually create sheaths around that nerve. But it's still something that's being researched, and there's some docs in South Korea that are really working on developing that. But I think it looks very promising for issues like this, where you have a nerve that's entrapped and we're trying to create space around it and create more liberty in that nerve's movement. Now, I doubt that we'll see a significant change, but we can take a look and see if there is any noticeable any change in movements within that nerve bundle. So here's that nerve again, right there. I know it's hard to see, but yeah. Now try moving your wrist again. Yeah, still not a whole lot of movement. Let me go above here. Here's the nerve. Alright. Try moving your elbow too. Yeah, it's still pretty entrapped in there. But we'll keep chipping away at this, and I think that as we get more of that nerve freed up from the scarring, it's going to get progressively more and more comfortable. But you can go ahead and sit up, Mr. Beaton. I'm all done. Let's see if anybody has any questions. And yeah. Well, no questions, but feel free to chime in. How do you feel, Mr. Beaton?
I feel good.
I put you through
good too. Honestly.
Does it good?
Yeah.
Good. Yeah. Usually after the injection, it should feel some better.
It does.
Does it feel different than the normal injections?
Yes, it does.
Because this one you're probably going to have a little bit more sensation with it,
I
like
do.
normal
I do.
sensation.
I do have more
Yep.
through here.
Good, good.
That's usually the pinky.
Yeah, yeah, and this
Yeah,
one
it's
goes
up
up a
through
little
here.
bit further.
Yeah.
Yeah, that's the difference between the kind of conventional stuff that insurance covers versus stuff that insurance doesn't cover.
Yeah.
And I think we can kind of push that margin a little bit more.
Like I said, I wouldn't do this if it wasn't working, and I've told you that before.
Yeah, I agree. Well, please feel free to share this video, and if anybody does have any questions, feel free to send us questions on Facebook or online. Be happy to answer them, and I'd like to continue these conversations. If there's anybody who has either carpal tunnel, cubital tunnel, tarsal tunnel, anything with a tunnel terminology in it, then typically that's what we're dealing with, is a nerve that's gotten entrapped or enmeshed in some scarring, and our goal is to try to liberalize that nerve and thereby reduce the inflammation, because it's a vicious cycle. Once that nerve gets irritated, it starts to swell. Once it swells, it has more reason to be irritated, and it just kind of keeps going in circles. But if we can get in there and start making some room for that nerve to move around, combine it with physical therapy where they're flossing that nerve back and forth, or using cupping or some other technique to help mobilize the tissue around that nerve, that's when we really start to see big differences. Anyways, thank you, Tina, for updating us on the heat wave in Denmark. Hopefully climate change isn't affecting you guys too much, but we're all facing that. And if anybody else has any other questions, please feel free to send us a message. Thank you for paying attention and chiming in. Talk to you soon.